Hi, welcome to EM Ready Canada, your ultimate review source for the CCFP-EM exam. Before we begin, make sure you subscribe, like this video to make sure that you receive all the exciting updates related to your preparation for the CCFP-EM exam. Without further ado, today we're going to be discussing airway and respirology, which are very high yield topics for the CCFP-EM exam. Specifically, we're going to look at some algorithms when it comes to decision making, diagnostics, and resuscitation protocols. So when we look at the universal airway, this is kind of a map or a schematic that we can look at airway assessment. And airway assessment is very important, whether it's a SAMP, whether it's an oral exam, you need to be able to demonstrate mastery of airway in emergency medicine. There's three different categories. We can think of this conceptually. There's a crash airway, a difficult airway, and standard rapid sequence intubation. Now, if we start from the most severe, the crash airway, what is the definition? The patient here is either nearly dead or is newly dead. So first and foremost, what we're going to try to do, because of the reflexes are usually not intact, we can attempt immediate orotracheal intubation without any sedatives, without any analgesia. If there is failure and we're not able to establish an airway, then we go to bag valve mask ventilation, and in which case paralyze, because there could be some residual reflexes still present, reattempt to intubate, and then use adjuncts if necessary. This is the crash airway. We go next to the difficult airway, which is kind of an in-between the standard rapid sequence intubation and the crash airway. So you'll see a lot of this, and a lot of questions are going to be focused on what's a difficult airway and how do you manage it. So first and foremost, we can anticipate whether an airway is going to be challenging, and if it is, and we're going to go into some of the criteria as to what makes a what makes an airway challenging. First and foremost, we want to request backup. So we want to, at the same time we're requesting backup, consider other avenues of non-invasive positive pressure ventilation. Here the objective is to maintain your O2 sats above 90%, so acceptable for life. And then we can consider either awake intubation, where some of the respiratory reflexes are still present, or adjunct-assisted orotracheal intubation. That means basically intubation, but using some types of assisted devices or adjuncts in order to facilitate that process. And that's the second category. The third category is your standard rapid sequence intubation. This is what we're all prepared, we're all traditionally accustomed to. Here, first and foremost, we need to prepare, pre-oxygenate the patient. We need to paralyze with induction, and we need to ensure proper placement of our tube. Now, in either of these situations, if these don't work, then you can have a failed airway, which means that there's an inability to establish an airway, in which case we temporize with BVM, bag valve mask ventilation, and if necessary, we consider a surgical airway, which is via a cricothyrotomy. So when we're looking at airway and anticipating possible difficulty or challenges in establishing your airway, there's a couple of different tools that we can use in terms of the airway assessment matrix. There's three different algorithms here, or acronyms, that we should be well aware of: Lemon, Moans, and RODS. So when we're talking about laryngoscopy, which is your standard regular intubation, we're going to look at Lemon. So what do we do to assess the airway? We look externally. This is the clinician's gestalt feeling of what, if there's any sort of external factors that are going to have an impact on the airway. Then we do the 3-3-2 rule. So evaluate the 3-3-2 rule. This is where we use our three fingers. We're going to go into what that is, but that's a rule that allows us to see if this is going to be a difficult airway or not. Similarly, we look at the M, the Mallampati scale, which gives us an idea of the patency and how difficult or not a potential intubation would be. Always for obstruction or obesity. So if there's any obstruction, if there's a tumor, if there's a lot of blood, or if the patient is obese, which are physical parameters that make intubation difficult, that's another factor to consider. And finally, neck mobility. So the N is for neck mobility. That allows us to determine whether or not we can properly position this patient in a sniffing position in order to intubate. So again, laryngoscopy, we're looking at lemon, look externally, evaluate the 332 rule, Mallampati scale, obstruction and obesity, and finally neck mobility. Now, going into progressively lesser intense forms of establishing an airway using a bag valve mask. Here we look at moans. So what are some of the things we need to assess to see if we're being efficacious in terms of our BVM? First is mask seal. So is there a beard? Is there facial hair? Is there trauma that prevents that kind of an asymmetry in the face that prevents a mask from properly sealing? Always for obesity and obstruction. Similarly, you're going to see that there was the obesity and obstruction on the laryngoscopy as well. But that's another factor, because when a patient's obese and there's redundant tissue, that can have an impact on the efficacy of BVM. Similarly, if there's an obstruction, that can have an impact as well. Older patients, so age greater than 55. Remember that age greater than 55 is a way you can assess difficulty for BVM. N if a patient has no teeth, and S if there is stiff lungs or chest wall. So stiff lungs or chest wall can have it can have an impact on the efficiency and how effective bag valve mask ventilation is. So again, laryngoscopy for intubation, we're looking at lemon, look externally, evaluate the 332 rule, M Mallampati scale, O obstruction obesity, and N neck mobility. Moving on to BVM, we're looking at moans. So mask seal, beard, trauma, obesity, obstruction, age greater than 55. N is the patient not having any teeth or edentulous that can have an impact on their bag valve mask ventilation. And finally, S, which is the stiff lung, stiff chest wall, has that restrictive aspect to it, and it prevents the effective bag valve mask ventilation. Finally, we can look at extraglottic devices. For instance, if we're putting an LMA or any other extraglottic device that we can use, here we look at rods, restricted mouth opening. So if you're not able to fully open the patient's mouth, that is going to have an impact on how effective your extraglottic device assisted airway is. Similarly, obesity, obstruction, which you're going to see as a commonality here for establishing an airway. D, disrupted or distorted airway. So if you have a trauma, if you have an anatomical distortion, that can have an impact. And finally, stiff lungs or stiff neck. That is one of the things that's going to have an impact on how effective your extraglottic assisted device airway is going to be. So rods, restricted mouth opening, obesity, obstruction, disrupted or distorted airway, and S, stiff lungs or cervical spine. So now let's look at the trauma airway in pleural space. Here, the clinical triggers when you have signs of attention pneumo. So what are the signs of attention pneumo? You have the patient is desatting, the patient's in shock, there's deviation of the trachea, absent breath sounds, and usually all of this is occurring in a context of trauma. So this is by definition, until proven otherwise, attention pneumothorax. So one of the first important things we need to do is recognize this and then act on it. So we need to do an immediate decompression, and this means before getting an X-ray, get an clinically based on your findings, do an immediate decompression, which is first and foremost a needle thoracostomy with a 14 gauge needle, second intercostal space in the mid-clavicular line, or you can do a finger thoracostomy, which is in the fourth to fifth intercostal space, anterior axillary line, and that is very important to recognize and act immediately. Now, definitive treatment is going to be a insertion of a chest tube. So first and foremost, we want to do an immediate decompression that stabilizes the patient physiologically. And then for definitive management, we need to insert a chest tube, 24 to 32 French, fourth to fifth intercostal space, anterior axillary line. Remember, this is exactly where we would have done a finger thoracostomy. So they go hand in hand. If you do the finger thoracostomy and immediate decompression, next step would be then to go ahead and proceed with a chest tube insertion. What do? We do local analgesia, horizontal incision, a blunt dissection, open up that pleural space, do a finger sweep, and go ahead and insert the tube and connect it to a pleurovac. So now what are we looking at here? We're looking at the obstructive airway matrix. So when we're looking at obstructive airway, we can consider asthma or COPD as the two most common sort of clinical presentations. There is some overlap. There are some differences. So onset in history in asthma, usually earlier onset, varying symptoms, and usually there's a family history versus COPD. We're talking about older age, chronic decline. Usually there's a smoking history, although 50% is underdiagnosed. Remember, COPD, chronic obstructive pulmonary disease. Asthma is usually an earlier onset. Pathology, highly reversible. So asthma, you can oftentimes reverse it with pharmacological agents, inhalers. COPD is usually, pathologically speaking, less reversible, and oftentimes you have chronic CO2 retention, so chronic hypercapnia. In asthma, critical caveats and death indicators, more than 2 hospitalizations per year, okay? More than 3 ED visits in a year, more than 2 short-acting beta agonist canisters per month, or a lack of symptom perception. These are factors that militate towards a more critical diagnosis. Versus COPD, oftentimes you have asthma and COPD that coexist. So undiagnosed COPD often presents as a primary severe exacerbation. So a patient may not already have a medical history of COPD. They'll have a severe exacerbation of their respiratory status. They present to the ED, and we have then evidence that there's probably underlying COPD in this patient. Once again, critical indicators for asthma, more than 2 hospitalizations in a year, more than 3 ED visits in a year, more than 2 SABA canisters per month, and a lack of symptom perception. So some of the things that we have to rule out, regardless of when we're looking at an obstructive airway, whether it's more of an asthma or a COPD type of presentation, we have to rule out the possibility of CHF, pulmonary embolism. So CHF, what we're going to do, we're going to check BNP, JVP, pulmonary embolism. Oftentimes in 20 to 25% of unclear COPD exacerbations, we're actually dealing with a PE. Acute coronary syndrome can also be something we need to absolutely rule out. Pneumonia, also something which is an infectious etiology that can kind of overlap with in the obstructive airway patient, and we need to make sure we rule that out. Here we're looking at the patient that's in status asthmaticus or a severe asthma exacerbation, and some of the escalation, what I call the escalation ladder. So in mild to moderate status asthmaticus, our O2 sat target is greater than 90%, greater than or equal to 90%. We want to give a salbutamol meter dose inhaler every 20 minutes, 3 times. So Q 20 minutes times 3 for an hour. We can give dexamethasone 0.6 milligram per kilogram, or a maximum of 12 milligrams, or PO steroids. This is now mild or moderate status asthmaticus. We go to severe status asthmaticus. Here you want to often give continuous salbutamol and ipratropium. This is usually nebulized. So atropine. We want to give this nebulized in a continuous fashion. We also want to give systemic corticosteroids. So here we're looking at IV steroids, and we can assess the response with bedside spirometry when you have less than 40%. That is, by definition, a severe case of status asthmaticus. Finally, we can look at impending respiratory failure. Now, in a patient with impending respiratory failure, we're going to be looking at mag sulfate, 25 to 50 milligrams per kilogram, or 2 grams IV over 20 to 30 minutes. Epinephrine, 0.5 milligrams sub-Q or IM. This is a 1 to 1,000 ratio concentration, or nebulized. We can also give ketamine. Remember, ketamine is a sympathomimetic that actually at a subdissociative dose can actually help. It's a bronchodilator. So 0.5 to 1 milligram per kilogram bolus IV of KET. And finally, non-invasive positive pressure ventilation, or BiPAP, can also be used for a patient with impending respiratory failure. And obviously, in case it goes south, we need to prepare for intubation. So here's the fourfold management of COPD exacerbations. One, first and foremost, we need to control saturation. So O2 sats need to be controlled. What's our target? Remember, 88 to 92%. Not looking for 94. We're not looking for what we consider normal SpO2. We're looking at 88 to 92% is our target SpO2. If the SpO2 is less than 90%, then we want to do an ABG to check for hypercapnia. And we also want to use non-invasive positive pressure ventilation early for respiratory acidosis. So consider BiPAP early on for respiratory acidosis. 2, we want to attack this with bronchodilators. So SABA and or anticholinergic agents, nebulized or MDI. We don't want to use long-acting agents like tiotropium acutely, but we want to use these bronchodilators in order to, again, open the airway. 3, we look at corticosteroids, a short course, about 5 to 7 days of systemic steroids, improves lung function, shortens recovery. So we're talking about pred 40 to 60 milligrams max. And again, a short dose, 5 to 7 days, we can avoid oftentimes some of those tapers. 4th, we have to consider antibiotics. Now, antibiotics are indicated for increased sputum volume, increased purulence. So there's different clinical classification systems that allows us to know whether there's an evidence of any sort of infectious etiology underlying the COPD exacerbation. Here we're targeting S. pneumoniae, H. influenza, and oftentimes what we want to use is azithromycin. We can use doxycycline, Septra, but azithromycin often is our most common tool that we use in terms of antibiotics. So here we're looking at pulmonary embolism, which is the diagnostic minefield. Why is it the diagnostic minefield? Is because it's oftentimes a silent threat. Up to half of PEs are diagnosed in patients with no apparent risk factors. And some of the most important diagnostic pitfalls to consider are first, premature closure. We're going to go in a later video talking about some of these clinical biases, so just remember this. But premature closure basically means where we're prematurely closing on a particular diagnosis. Because PE patients have overlapping symptoms with COPD exacerbation, pneumonia, and CHF, sometimes we think and prematurely close our consideration onto these other clinical pathologies, missing a critical diagnosis of a pulmonary embolism. Second diagnostic pitfall is kind of over testing or doing the opposite. So here is where the danger is assuming low risk patients may have a PE and therefore subjecting them to CTPAs, which has significant radiation risk, false positive risks, and also putting these patients on anticoagulants means that we're also subjecting them to risks of undue bleeding. So solution is to be very algorithmic in terms of stratifying patients to safely rule out PE without unnecessary testing. So when we have a suspected PE, a patient comes in with a clinical criteria or presentation that's compatible with the PE, one of the first things we do, use a clinical prediction rule, whether it's the Wells test, Wells criteria. When it's low risk, we can use D-dimer. If it's negative, we can effectively eliminate the diagnosis. Intermediate risk, D-dimer. Again, if the D-dimer is positive, then we can go ahead and appropriately manage that with the appropriate diagnostic test. Finally, high risk is for CTPAs. High risk, you're going to essentially subject the patient directly, send them directly to do a CTPA or a VQ scan, which is the appropriate management and will allow us to really appropriately determine what we're dealing with. If it is indeed a PE, which we can tell definitively on one of these scans, or if it's not, then we consider other possibilities. Now let's look at the objective stratification tools that we use for PEs. We talked about Wells score. So a Wells score is composed of several different factors. First, your clinical signs of a DVT, which is worth 3 points. Alternative diagnoses, less likely than PE, is also 3 points. When your patient is tachycardic, heart rate more than 100, that's 1.5 points. Prior history of a VTE, 1.5 points. Immobilization or surgery for at least 4 weeks. When I say immobilization or surgery in the past 4 weeks, excuse me, that's 1.5 points. An active malignancy, remember active malignancy, 1 point. Hemoptysis, 1 point. So when we tally these all together, it gives us a total, and a score greater than 6 is considered high risk. 2 to 6, moderate. Less than 2, low. Another way to look at it is making it dichotomous. So below 4.5, PE is unlikely. Above, greater than, or equal to 4.5, PE is likely. Now, when we're looking at low risk, then we can apply the PERC rule, because if all 9 of the following criteria, which is your PE rule out criteria, are all met, then we can effectively rule out the possibility of a PE. One is your low clinical gestalt, so low clinical impression. Patient's young, below 50. Heart rate is less than 100, so they're not tachycardic. They're satting well, so SpO2 is greater than 94%. There's no evidence of hemoptysis. There's no prior VTE, no recent surgery or trauma, no estrogen use, no unilateral leg edema. If all 9 of these are present, remember, then we can effectively rule out a PE in your low risk patients. So we start with the Wells score, low risk, high risk, or PE likely or PE unlikely. When PE is unlikely, then we can apply PERC. If all 9 of the PERC are met, we can effectively rule out the possibility of a pulmonary embolism. Here we're looking at the PE diagnostic filter funnel. So when we have a suspected PE, we look again, this is kind of like what we just summarizing what we talked about. We have a suspected PE, we look at a pre-test probability, so we look at the Wells score. If The wells, if we look at the alternative dichotomous binary system, if it's greater than or equal to 4.5, PE is considered likely. We go straight to a CTPA. So CT pulmonary angiography, your gold standard to look for the presence or absence of a pulmonary embolism. When your well score is less than 4.5, then we apply the PERC. If all of the 9 criteria of the PERC rule are present, so all of them are negative, we can effectively say the patient doesn't have any of those factors, then we can rule out PE and consider an alternative diagnosis. If even one of them doesn't apply, then it's considered positive, so they fail the PERC, and then we do a D-dimer test. If D-dimer is negative, again, we can rule out PE. If D-dimer is positive, then we go ahead and do a CTPA or a VQ scan if the patient has a contraindication or if there's renal impairment. So now we've made the diagnosis of a pulmonary embolism. So what are the treatment pathways? We can divide all the way from low risk PE all the way to a massive PE. So let's start with massive PE, the most deadly. Here is a patient that has signs of hemodynamic instability. They're in shock. Oftentimes this is refractory. And what do we want to give in these patients where we have evidence of a massive pulmonary embolism? We want to give systemic clot busters, so systemic thrombolysis, RTPA, 50 milligram bolus, then 50 milligrams over 2 hours. Consider ECMO. This is a critical pathway. We have now the mid, which is kind of like a submassive PE, so it's a significant PE, but it's not a massive PE. Here on POCUS, we're going to see RV dysfunction, so right ventricular dysfunction. We're going to have elevated troponin, elevated BNP. Here, what we want to do is we want to admit the patient. We want to put them on low molecular weight heparin, so like Lovenox, and we want to monitor them for deterioration. If they deteriorate clinically, we may need to do what's known as rescue thrombolysis or rescue, providing them those systemic thrombolytic agents like RTPA. Again, this is a caution pathway, so it's not a massive, but it's not something that you want to take lightly either. Finally, we have a low-risk PE, which is a patient who is hemodynamically stable. They have a normal RV function. Their SPESI score is 0. We're going to talk about that. And what are some of the interventions here in this case? Outpatient ambulatory care. We can give apixaban 10 milligrams twice a day for 7 days, then 5 milligrams twice a day. And again, this is your standard pathway for patients once they have a diagnosis of PE. Now, the exception is for pregnant patients. Now, there's diagnostic deviations as well as therapeutic deviations for this specific special population of patients. When we're looking at a pregnant mother, the D-dimer test is less reliable because there's a natural elevation in pregnancy. So a negative result still has rule-out value in early stages, but again, it's less reliable as a diagnostic tool. Imaging choice, we often want to avoid radiation of maternal breast tissue, so we'll use VQ scan. Although CTPA is often still used if a chest x-ray is abnormal. So if the chest x-ray is normal and we're still considering the possibility of a PE, then usually we'll do the VQ scan in order to protect the maternal breast tissue. If the x-ray is abnormal, then we'll go ahead with a CTPA. It's more reliable as a test. In terms of therapeutically speaking, DOACs like apixaban are avoided in pregnant patient. Our first line treatment is low molecular weight heparin or Lovenox. Again, we look at dalteparin, 200 units daily or 100 units per kilogram BID. And we can also use enoxaparin, 1 milligram per kilogram BID. We had previously talked about the SPESI that I mentioned on the previous slide. So SPESI is your simplified pulmonary embolism severity index. Now, if any of these are positive, the patient is considered high risk. So age, if the age is above 80, that's high risk. History of cancer, if there is a history of cancer, that's high risk. If there's a history of chronic cardiopulmonary disease, that's high risk. If the patient has a heart rate greater than 110, so not your standard 100, but 110 beats per minute, that's considered positive on the SPESI and therefore high risk. If systolic blood pressure is less than 100, again, high risk. And if O2 saturation is less than 90%, those are also considered high risk. So here we're looking at the undifferentiated dyspnea, and here's a checklist that we can use. First, assess your interface. Okay, differentiate upper versus lower airway pathology immediately. Is this an upper obstruction? Is this a lower infection, for instance? Those are things that first and foremost we want to look at. We want to be able to also broaden the differential. So look for coexisting etiologies. There could be underlying pneumonia. There could be a precipitating CHF. So these are factors to consider when we're looking at dyspnea that's been undifferentiated. Beware the unrelated hit. Seek unrelated acute causes in chronic illnesses. For instance, even with the patient with baseline COPD, they can have an acute on chronic manifestation like a COPD exacerbation, or it could be something totally different like an acute pulmonary embolism. Fourth, you want to look outside the lungs. Okay, look at cardiac issues, metabolic acidosis, anemia, toxicology, CNS pathology. So outside of the respiratory system, and I would argue outside the cardiorespiratory system, in order to look at possible other causes of your undifferentiated dyspnea. And sometimes you also often want to treat before confirming. So you can initiate non-invasive positive pressure ventilation like BiPAP, give some therapeutic agents like beta agonists based on your clinical presentation prior to definitive diagnoses. So again, what's the underlying theme here? For the CCFP-EM exam, we need to look at the respirology resuscitation paradigm. So we need to consider anticipation of whether this is going to be a difficult, a crash, or a standard airway. Consider aggressive early intervention, especially when we're looking at the lungs and establishing a positive, establishing a patent airway. We want to reverse pathophysiology early. So oftentimes, for instance, escalating from salbutamol to magnesium or ketamine to non-invasive positive pressure ventilation and status asthmaticus. And we also need to look at objective stratification. So we need to look at the vasculature, consider paradigms, clinical testing, like for a PE, to make sure that we're not excluding other possibilities that can be causing the actual symptomatology of the patient. When we're looking at anticipation, remember the lemon the acronyms that we looked at. We talked about MOANS for BVM, and finally RODS for supraglottic assist in establishing an airway. So what is the commonality in this? The theme is that we need to be very disciplined when it comes to applying the algorithms with a willingness to escalate the therapy ahead of the crash. Hopefully you enjoyed this video. Remember, this video does not take place for clinical judgment, nor is it being presented as medical advice. It is a study tool for you to perform well in the CCFP-EM exam. And make sure you subscribe to the channel, like the video, and be aware of any updates, and look forward to reading all of your comments and responding to everybody, and really accompanying you on your study path. Thank you.